So basically, the door-to-unload STEMI trial, I think the first slide was a little different, is really based on one fundamental concept, which is that heart attacks lead to heart failure. And this is something that everybody is familiar with, that we're seeing an exponential growth in the number of heart failure patients. And what we've also learned is that the treatment for heart attack, we have one treatment today, which is a door-to-balloon strategy. And the paper that Jim Udelson referred to earlier in the day between him and Greg Stone essentially showed that despite a contemporary door-to-balloon strategy where we're seeing door-to-balloon times of around 60 minutes across the United States and certainly less than the 90-minute target, we're still seeing that for every 5% increase in the infarct size, there's a 20% increase in one-year heart failure hospitalization and a 20% increase in one-year mortality after a heart attack. And so the question is, how do we move the dial in terms of infarct size reduction? And if we can reduce it by 5%, those downstream benefits may be there. So in 1971, Morocco and Brunwald suggested that there are two approaches. One is reperfusing the artery, and the second, which was a fascinating concept back then, which is to reduce myocardial oxygen demand and then open the artery. And if you can do that promptly, then you might be able to reduce the size of the infarct. And of course, as we all know, since then, the balloon angioplasty the advent was in the mid-1970s, and subsequently we've seen that become our primary strategy. But what we also saw around the same time in the 1970s was a series of preclinical studies testing this concept of reducing myocardial oxygen demand. And this was done through reducing heart rate, reducing wall stress, reducing stroke work, primarily through pharmacologic approaches. But what we also observed back then was that there was an emerging science around mechanical unloading and using mechanical devices to unload the heart before reperfusion. And these started with the intra-aortic balloon pump. This then became the left atrial to femoral artery bypass. We have some of the pioneering scientists here for LAFA bypass, surgical implants. Then that went to the tandem heart device, then to the hemopump, which Dan mentioned early in the morning, predecessor to now the Impella technologies. And if you look at the blue box in the center, what you see is that the learning over the decades was that you have to implant and unload the heart before, not after reperfusion. And that really is a disruptive step in terms of contemporary clinical practice. And so this is summarized here in terms of what the learnings were from across those 4 decades of science. And of course, you've seen a lot of science in that bottom panel about the effective transvalvular pump activation. And the introduction of this concept of delayed reperfusion is one that began probably about 6-7 years ago in our laboratory, where we saw that not only were you unloading before reperfusion, but actually if you waited about 30 to 60 minutes before reperfusion, we were getting the most effective reduction in myocardial infarct sizes. And so from 2012 to 2018, we've now started working, as you've seen through a lot of the science today and over the ACURE years, a lot of the mechanism behind that biology. But the takeaway message is that transvalvular unloading limits myocardial ischemia and promotes a cardioprotective shift in myocardial biology. So the rationale for the door-to-unload pilot study was founded in this preclinical study, where we tried to replicate what would be clinically reasonable to do in the setting of a heart attack. So the first group is reperfusion alone after a period of LAD occlusion in these swine models. The next group is the other white bar, where we said, well, what if we do something that might be most acceptable to physicians, which is to unload after you've already reperfused the artery. And we saw that in both those groups, there was no statistically significant difference in the infarct size. And so then we tried to hedge our bets a little bit, and we put in unloading and said, what if you unload and then open the artery immediately after? And that takes about anywhere from 5 to 15 minutes. And again, didn't see a significant reduction in the infarct size. But we saw that with 30 minutes of delay, we saw a significant reduction in the infarct size compared to reperfusion alone. So the pilot study was primarily focused on these two groups in the middle, because the question is whether or not this translates into patients and into practice. So clinically, what we needed to answer before doing a pivotal trial comparing against the standard of care, which is reperfusion alone, was to test whether or not, first of all, it's safe, whether it's feasible, and whether there was any early sign that this 30-minute delay was actually leading to an effective reduction in infarct size. And so that's the rationale of doing a pilot before we do a pivotal. And so the door to unload STEMI pilot study, the central hypothesis was that compared to LV unloading and immediate reperfusion, that LV unloading followed by a 30-minute delay to reperfusion is feasible and safe. And the readouts of feasibility and safety are shown here. Number one was successful enrollment and protocol completion. The second was no increase in major adverse cardiovascular or cerebral events at 30 days, and then no increase in infarct size between the groups, again suggesting that it's safe to delay 30 minutes without increasing the infarct size. And so the study design was shown here. It's a phase 1 safety feasibility multi-center pilot, 1-to-1 randomization to unloading and immediate reperfusion or unloading and 30-minute delay with independent data safety monitor, electrocardiographic, angiographic, and CMR core labs that are blinded to patient randomization. And you can see here from the study design, the real question around feasibility was not a simple one. And as Haroon just nicely illustrated, the idea is taking someone with an anterior STEMI, reading the EKG, confirming that this is truly ST elevation greater than 4 millimeters in the precordium, completing informed consent and enrollment, then prepping, draping, anticoagulating, antiplatelet therapy, ultrasound-guided access, vascular angiogram, LV-gram, 14 French sheath insertion, and then you randomize, and then you put in the Impella pump, and you activate it. And then you're randomized to those two arms of delay by 30 minutes or immediate reperfusion. And you got to do that with this mantra, which we still believe is true, which is that time is muscle. And so I think it's a reasonable question is all of that feasible to do before you go on to do a pivotal? And so that was the way the study was designed. And so this really boiled down to technical feasibility, and this required optimal team dynamics. We've got Melissa from our laboratory at Tufts who's here with us today, and she was assigned team leader for door to unload STEMI, and her job was to run through ACLS level codes where we kept rehearsing the door to unload strategy with immediate or delayed. And as you can see, based on Melissa's efforts and the rest of the team, with this particular case at Tufts, we had 27 minutes from door to Impella unloading. We then had the 30-minute delay, and then we had balloon reperfusion, all done in 67.48 minutes for a total door to balloon time. So feasibility, yes, and then the question is, can you replicate this in 15 centers with multiple operators around the United States? And so the trial was successfully completed. The results, of course, will be Sunday morning as an AHA late-breaking science session at 10 a.m. We do have co-publication of these findings in circulation that are coming up, and we are still under embargo. So I do want to acknowledge, of course, the DTU STEMI trial investigators. As you heard from Haroon, it takes a certain type of person to engage in this type of disruptive science, and a person who believes that the science is going to advance their patients' outcomes and improve care for society. I also wanted to highlight Bill O'Neill, who couldn't be with us today, and also just emphasize the amount of leadership that he implemented in the study execution and analysis of the results. So the title of this talk was supposed to be, what does this platform create for us? So the door to unload STEMI pilot is the first step towards developing a physiologically integrated approach to acute MI therapy. And what we're suggesting is that LV unloading is cardioprotective. And I think that's basically the take-home message of the entire ACURE forum, but also just really emphasized by this first translational study that goes into man that you'll hear on Sunday. And what you see here is a very nice physiology paper from the 1980s, which linked cardiac muscle, coronary vasculature, and then all of the mechanical and hemodynamic and metabolic interaction that occurs between these two systems. And so what we think is that if we're successful with the pivotal, that we may have developed a platform for further investigation. Everything you heard today is potentially DTU STEMI 1, 2, 3, 4, 5 going forward. That includes the 30-minute of delay. In our practice, we implemented some IV beta blockade for these hypertensive patients who are tachycardic to reduce wall stress further and enhance that cardioprotective effect. There were a lot of use of intracoronary vasodilators. Should we do this with glucose, insulin, potassium infusions, relatively cheap and potentially effective on mitochondrial preservation? SDF1, a number of other things, including neuromodulation you've heard about today. So if this trial is successful, then ACURE now starts to launch into essentially a trial design meeting for future studies that target unloading. And this is an illustration from one of our patients who came in, heart rate of 115, anterior STEMI. You see the LVEDP of around 20 to 25. We're 30 minutes of unloading. And you can see here immediately post-PCI, the patient had gotten 5 of metoprolol only, some nitroglycerin, pain-free, and you can see the tracing there, a really nice LVEDP reduction in the heart rate significantly, and then also the unloading signature on the aortic tracing as well, suggesting that we've got this patient nicely unloaded. And so what I think we're going to see going forward, one of the earliest things that I think we should be thinking about is using DTU platform therapeutics, for example, targeting the ischemic side of ischemia reperfusion, and this can be done by beta blocker therapy, so the BEAT AMI study that was published in JACC. This illustration of this figure shows that what they found in the study was that the more prolonged time you had from the IV beta blocker therapy to reperfusion actually correlated with more benefit in terms of reduction in infarct size. So the idea is, can you give the drug therapy and can you delay the reperfusion? And I think on the backbone of a mechanical unloading platform, this could be a really exciting combination approach of drug and device that is clinically reasonable. And of course, the idea of targeting ischemia and then reperfusion injury itself still remains a holy grail. And if you do reperfuse, when is it safe to reperfuse? And do we give drugs that should potentially affect reperfusion itself? The adage that time is muscle still holds in place. These are all the mechanistic things that we talked about today. And the question was, how do you stop this myocardial injury clock? And now with the backbone of mechanical unloading, we think that you can do that using these multiple mechanisms of oxygen demand, collateral flow, mitochondrial preservation, SDF1, and risk pathway activation, and now targeting some of these specific aspects of the reperfusion injury cascade with drug therapy, but on the platform of unloading. And so we've piloted this concept, so the idea would go back to an over-the-wire balloon, and it may be that you may find in the next decade or two that actually the way to do this is to go in with an OTW balloon, inflate the balloon, occlude the artery, and through that over-the-wire balloon deliver intracoronary therapeutics that target reperfusion injury, give that delay on that platform of unloading, and then start to see that you've actually done it through a 2-hit mechanism. And I think that's sort of a next step if we're successful with the rest of the DTU pilot and pivotal program. And of course, the targeting of complex 1 is, you heard about from our laboratory. There are a number of drugs that we talked about with Bob Kloner that are targeting this complex 1 approach. Commercially available drugs like ranolazine, which could obviously come into play to be given during a door-to-unload platform approach. So we'll see whether or not we're able to actually engage around targeting ischemia and reperfusion. We think that the other platform that the door-to-unload trial would potentially lead us to is further delays to reperfusion. And there was a postulate put forward. I got an email from a surgeon in Canada who said, "Why reperfuse?" And I thought it was a provocative concept. I suggested that we perhaps talk in person and not on documented email. But basically, it is a potentially paradigm-changing concept that you would get unloaded and then you would come back at a certain time point and reperfuse. I'm not going to advocate for that at the safety feasibility pilot trial discussion, but I do think that we are opening an entire window of opportunity during that green phase of unloading. And the question is, what's on the other side of the window? So I think Bill, on one of our PI calls, framed it perfectly by saying that the pilot trial is just the end of the beginning for not only DTU, but also for ACURE. These are all the ACURE meetings that we've gone around the world with. And in a very short amount of time, partnering with Abiomed has been a phenomenal experience to engage with a company that is 250% focused on innovation and execution of ideas that we think are safe, feasible, and could have a beneficial impact on society. So I also want to thank the ACURE group and all of you investigators who joined us today. because it's with your encouragement and with your science that allows us to keep pushing forward on these disruptive pathways. So thanks very much for your attention.
Yeah, really, thank you very much. This is really that what I thought that must be the consequence of all that meetings and that what we had heard today. But still, my question, why only 3 hours?
Yeah.
Why not 2 days or 3 days? Why not?
I think it's a great question. So, remember, this is a safety feasibility pilot. So that's answer number one, is just from a practical perspective, we've got to get in, we've got to get out. Now, without breaking embargo, there are certainly patients who require support beyond 3 hours. So the recommendation was a minimum of 3 hours of support. What we didn't want is a high-risk PCI approach where it comes out at the end of the case. But I think going forward, again, it's another window of opportunity to answer that question. It may be, as you suggest, that we should be unloading for longer periods of time, that the reperfusion injury phase, that all of the renal aspects, the metabolic shift that we've talked about today, which we're just hearing about for the first time here at ACURE today, may in fact become a part of this trials going forward. But we would love to be able to test that question. We just have to prove that it's safe and feasible, which is why we chose a minimum of 3 hours.
Yes, I totally agree. Any questions? There's one.
How is Impella support titrated to ensure adequate unloading?
It's a great question. And, Haroon's case hits on that point perfectly. With a blood pressure of 198, putting in an Impella in someone who is hypertensive, one of the first things we had in our first PI call after initial enrollments was, are we actually unloading? And so, does the device have the capacity to overcome that type of afterload? The goal is that it's door to unload, not simply door to Impella. So I think that's the heart of your question. So you'll see some of the data starts to get towards that question. But yes, the idea was to run patients at P8 and make sure that they're not only getting adequate RPM settings, so there was no titration at that point. You want to be maximally using the pump as much as possible, optimal positioning. But there's that other element that, if you've got a hypertensive patient, now you can start to give things like nipride, like nitroglycerin, and doing it through an intracoronary mechanism or systemically. I think operators, because we saw that they were getting comfortable during the 30 minutes of unloading, were now being able to think outside of the coronary and starting to think like physiologists. And they said, well, should we give beta blockers now because we've got still a hypertensive patient? Should we give some IV nitro? Can we start to modulate the hemodynamics to achieve on this platform of unloading, which you couldn't do if you didn't have the pump? Because if you started giving nipride and systemic vasodilators and beta blockers to a non-supported patient, you're at risk of creating cardiogenic shock and hemodynamic compromise. So more to come on that.
Apparently, you included patients with whatever the TIMI flow was at admission, including patients with TIMI 2 or 3 flow, which by definition should already have had reperfusion injury. So wasn't that a risk of...
Yes. So we really thought about the TIMI flow, and the real question actually from a study design was when to do the angiogram. So remember, the patients are coming in, and we want to get them unloaded as quickly as possible. And so the easiest route would have been do an angiogram, confirm LAD occlusion, and then go on pump. The problem is that we're still delaying, and also by injecting contrast and getting access for the coronary angiogram, it would delay us to getting to unloading. So we decided to take that leap of faith and say we're going to trust the EKG, go onto unloading based on ECG and left ventriculography from the groin. And the timing of the angiogram is really an interesting question that I think we'll be discussing more, which is we recommended that operators, especially in the delay arm, unload and not perform an angiogram until after 30 minutes of unloading. Primarily because there was concern that with a contrast manual injection that we may dislodge the thrombus, we may be affecting coronary flow dynamics, and we wanted to allow the pump to just unload by itself. And so you'll see some data that starts to point at this question of the impact of TIMI flow and the impact of unloading on TIMI flow.
Thank you for mentioning the Peter Morocco paper. Actually, he came to Philadelphia, and I was in a lab. I think I was getting coffee for people. That's kind of the level I was at. And that protocol was to infuse the beta blocker through the coronary sinus. And with that in mind, because there was no stent in 1976, as I said, I was bringing coffee. So would that not be an advantage in the protocol you're describing? Obviously, the protocol is what it is to give a beta blocker before you open the vessel through the coronary sinus with a balloon to make sure it actually gets to the target post the infarct area.
Yeah, so I think, again, the theme of the talk here today is platform, door-to-unload, unloading platform therapeutics. And so you could envision many, many adjunct approaches. And that, I think, is what is most exciting about opening up this new space of investigation. And the idea of doing it through the coronary sinus or even systemically. And as we showed, giving beta blockers is something that most operators are comfortable doing, especially if you're on an unloading pump. But the idea of doing it through the CS, I think even the Pixo device and a number of technologies coming out for reperfusion injury could now be reintroduced on the platform of unloading.
When you have unloading and in these 30 minutes you do nothing, probably you use this time and start with IV beta blockers to prepare that
Yeah, and I think we're going to have a panel discussion around the trial design, and I think that's one of the questions is, do we protocolize that?
After the revascularization of the primary lesion, during that 3 hours of periods of time that you have the pump on and you're continuing to support the ventricle, does your current protocol or will future protocols include complete revascularization for other lesions that you find?
Great question. So, we did not want to protocolize that approach. So it's left to the operator's discretion. Of course, we've got to get culprit PCI as the focus. If there was a strong rationale for doing non-culprit PCI, it's totally up to the operator at this stage. I think we have equipoise around that, especially on unloading. And I think it's another area for further investigation. And I think this may be where we start to see FFR come into play, and a lot of the work that's done to assess those non-culprit targets could also come back into play. But we wanted to avoid that. We didn't encourage any FFR. It's giving adenosine, which would also potentially impact our infarct readout. Great. Thanks very much.